I'd like to welcome everyone to tonight's lecture, which is called Sleep and Sleep Health, Your Brain Explained, where I'm about to welcome Dr. Daniel Barone. My name is Kayla Del Biondo. I'm the coordinator of adult programming and outreach at the library, and we're expecting a pretty large crowd tonight, which is exciting. So welcome back to those of you who've been coming to our live lectures online, and if you're new, welcome also. So without further ado, I'd like to introduce Dr. Daniel Barone. Dr. Barone is currently the Associate Medical Director of the Weill Cornell Center for Sleep Medicine and an Associate Professor of Clinical Neurology at Weill Cornell Medical College, as well as an Attending Neurologist at York-Presbyterian Weill Cornell Medical Center. He specializes in the evaluation and management of patients with all forms of sleep disorders, including sleep apnea, restless leg syndrome, insomnia, and narcolepsy. He's certified by the American Board of Psychiatry and Neurology in both neurology and sleep medicine. Dr. Barone is the first author of multiple peer-reviewed publications on a variety of topics in sleep medicine, and he has appeared in several media pieces. His first book, Let's Talk About Sleep, was published in 2018, and I think he's going to talk about that a little bit at the end of his presentation. For those of you who are on with us tonight, I just want to also plug, we had one of Dr. Barone's colleagues last month talking about brain health and concussions, and we're going to have another one of his colleagues joining us on May 4th at 7 p.m. to talk about the prevalence and prevention of Alzheimer's. So I encourage you to register for that on May 4th at 7 p.m. if you haven't yet. So I will go ahead and turn it over to Dr. Barone. Thanks for being here tonight.
All right, thank you, Kayla. Nice to meet you all virtually. These are strange times, so this is the way it is. Yes, we are going to be talking about sleep and sleep health. Hopefully, you won't fall asleep during this lecture. That was joke intended. So why don't we get started? If you hear background noise like police sirens and whatnot, I'm in Manhattan, so right outside my window is a lot going on. So anyway, here we go. All right. Think in the morning, act in the noon, eat in the evening, sleep in the night. That's from William Blake. Laugh and the world laughs with you, snore and you sleep alone. So before we talk about the disorders of sleep, it's important to talk about what sleep does for us. And one of the ways we know how sleep helps us is we see what happens when we don't get good quality or good quantity of it. Okay, that's going to be a theme I keep mentioning throughout this talk is it's not just sleep quantity that matters, it's sleep quality, okay? So one of the biggest things that sleep helps us to do is solidify our memories, all right? So I can tell you from my own experience when I was in residency or medical school or even beyond before that, if I pulled an all-nighter, which I don't recommend people do, if I did and I was studying, whatever material, I could not remember it until I took a short nap, half an hour nap, and all of a sudden I was able to retain that information. Sleep helps us to solidify those memories, and we're not even sure how it happens or why it happens, but it does. Okay, so one of the things that we get lost, when we don't get good quality sleep is what we call executive function. So that's things like memory, that's things like reaction time, which we'll see in a second. Okay, so we know that sleep helps us because if we don't get it, these things they suffer. So as strange as it sounds, the field of science, sleep science, has not been able to answer the question of why we sleep. Okay, we know sleep helps us, like we said, with executive function and memory and things like that. But what is it actually doing for us? And there's been different theories put out over the years, of the last 1,000 years or so, but nobody was really ever to know for sure until more recently. So 2013, researchers out of the University of Rochester, I believe, they took a study of mice and rats, okay, and their brains and what happens when they go into sleep. What they found was that, so in the brain we have our neurons, which are basically, they do everything we think about a brain does, memory, personality, all that stuff. And then they have supporting cells. So these are called glial cells, okay? So the glial cells kind of nourish the neurons and provide them with energy and whatnot, okay? So what they found was in these rats, when they went into deep sleep, the supporting cells actually shrunk down, okay? And what that did was it allowed kind of like almost like a convective current to cycle through the brain, okay? Cycle the fluid through the brain, and in doing so, remove the toxins away from the neurons, okay? So every cell in the body, when we go through our daily life, takes in oxygen and other nutrients, and then it produces waste, carbon dioxide and other things. Every cell in the body, aside from the brain, has what's called the lymphatic system. Maybe you've heard of that, lymph nodes and whatnot. So what happens is the lymph nodes basically take the waste away, and then we put it into the venous system, and then we either urinate it out or excrete it in other ways. Okay, the brain doesn't have that. The brain doesn't have that lymphatic system. So what was found in these rats is when they go into deep sleep, these supporting cells shrink down, and it allows kind of the clearing away of the toxic proteins that build up. Now, how does this matter to us? Years later, about last year or so, they found that this process happens in humans as well. Okay, and why does this matter? Because what this is saying is that neurodegenerative diseases like Alzheimer's, like Parkinson's disease, we think that they come on because there are toxic proteins and toxic metabolites, we call them, left behind over decades, not one night, but decades. And what happens is the theory is when people are not getting good quality sleep, again, they're not getting that deep sleep that we're talking about over many, many decades, that can allow for these toxic proteins to build up. And that's what can lead to, or be one of the reasons why someone may develop a neurodegenerative disease. Okay, something to think about. Along this path, sleep is necessary for cognition. So like I said, memory, storing memory, reaction time, cognition, our ability to think and make decisions. All these things get affected when we don't get quality sleep. One of the most interesting studies to highlight this has come from about 15 years ago or so. And what the researchers did there was, I believe this was out of Harvard, they took 4 groups of people, 4 groups of healthy people who had no problems, okay? And what they did was they had them either have either 0 hours time in bed, 4 hours time in bed, 6 hours time in bed, or 8 hours time in bed over a 2-week period. And over a 2-week period of time, they had them do this task. Okay, it's called a psychomotor vigilance task. And basically what that is we've all done it before. It's you see a dot on the screen, you press the button. Okay, so it's over an hour or so, let's say. And people make mistakes, especially if they're tired. They'll either forget to press the button, or they'll press the button when the dot is not there. Okay, so it's a measure of somebody's attention, ability to pay attention. Okay, so the folks in red, these folks had 0 hours time in bed. Okay, so they weren't sleeping at all. They stopped the study after 3 nights. You can't imagine that they would do that for 2 weeks. They wouldn't be alive. But after 3 nights, you can see that the amount of mistakes. So what we're looking at here, the x-axis is days of the test, okay? And then the y-axis over here, y-axis is the amount of mistakes they were making on this test, okay? Again, this is a test of attention. So after 3 nights of not sleeping, the amount of mistakes shot up, okay? That's no surprise. The folks in blue, okay, they had 8 hours time in bed. So these were people who had no sleep restriction or so, okay? The amount of mistakes they made went up a little bit, okay, probably because they were bored and doing the same kind of task over and over again. Not a significant difference. But the folks who are really interesting are the yellow and the green, okay? So these are 4 hours time in bed, 6 hours time in bed. And what they found here was, over the 2-week span, you can see that the yellow guys actually had more mistakes, okay, than the ones who had no sleep at all, and the green basically almost matched them. Okay, now that's what that's saying is basically, so if somebody has, let's say somebody needs 8 hours of time in bed, let's say they need 8 hours of sleep, but they're only getting 6. That basically means at every night they're 2 hours deprived. So after 2 weeks of that, it's like not getting a night of sleep or 2 nights of sleep. Okay, so the amount of mistakes that they were making is going to increase. Okay, that may not surprise you. But what did surprise people, and what's interesting about this study, is about day 7, right here, they asked everybody in the study, they said, how's it going for you subjectively? Are you feel like you're doing well? Do you feel like you're getting used to this process of being only spending 4 hours of time in bed? Every person across the board in the study said, yes, I feel like my brain is, quote, getting used to this study. I'm getting used to the fact that I'm not getting as much sleep and my body's adjusting to it. Well, that's not what happens. And we see that from this study, right? So there's a difference between our objective abilities and our subjective experience. Why this matters? Because when we talk about somebody who's sleep deprived, they get out on the road, right? What do you need on the road? You need to have good decision-making skills. You need to have be able to stay attention, stay focused. And what this study is showing is that when we have chronically low amount of sleep, our body's ability, our brain's ability to stay focused goes down. Okay, and this is another thing showing us, another study showing us how important sleep is for our brain, okay? A very, very common thing I see in my patients is people will come to me and they will have undiagnosed or underdiagnosed depression or anxiety, okay? And a well-known phenomenon is when we're not sleeping well, clinical depression, clinical anxiety, they will get worse. And when clinical depression or clinical anxiety are present, they will make sleep worse. And it kind of becomes this vicious cycle, right? One of the treatments for depression and anxiety is getting good sleep. So what I'll tell my patients is, look, we have to work on the sleep part, but you also may really want to consider a therapist, a psychiatrist, someone of that nature to help you with these other things. Because what I always say is if you're treating one but not the other, chances are both are still going to maintain, both are still going to be left behind. So it's very important if there is some underlying anxiety or depression, especially in these times, with the pandemic and the stress, it's important to get that looked at if that's a problem for you, okay? So that's mental health. Physical health, sleep is very, very important for us. And I just put on here one study, this small study, but basically what they had was they took these radiologists who were on a 24-hour call. They only slept about 3 hours or so. And what they did was they measured them before and after their shift, okay? And what they found was even after just one night of poor sleep or not getting sleep, blood pressure was up the next day, inflammatory markers were up the next day, cortisol was up the next day, blood sugar was up the next day, okay? Now, over one night, this means nothing, right? Nothing's going to happen to them. But if we blow that out over, again, 10 years of nights, 20 years of nights, you can see how poor quality sleep or poor quantity of sleep can really affect somebody's health, okay? And I have here down in red, immune system, right? What does that matter? Because we're living in a situation where there's a pandemic, right? We're exposure to virus. A lot of studies have shown that when people get less sleep than they need, their ability to fight off cold or a virus goes way, way down, okay? So very important, especially in these days. So that's how we know sleep helps us. Now, if we're concerned about somebody having a sleep disorder, what we'll do is we'll have them come in for a sleep test, ideally. Okay, and although in this day and age, insurance has kind of run the game, but we have to do home tests a lot. But in an in-lab test, what we're looking at is a lot of different stuff. It's not simply just what happens when the brain goes to sleep. We're looking at the body. We're looking at the breathing. We're looking at the heart rhythm. We're looking at if there is any abnormal movements in the arms or legs. Okay, and that's kind of this gentleman here showed it all wired up. Any of you folks who have had a sleep test can attest to this. A lot of wires. But what I always tell my patients is I'm not looking to see, person X got 8 hours of sleep. It's not going to happen. What we are looking to see, though, is within the hours of sleep that you do get, let's say 4 or 5, whatever it is, what's happening that makes those hours problematic. Okay, and we will see that. Just to kind of to show you this, if you look down here on the bottom right, this is just showing the difference in brain waves, okay, as we go into different stages of sleep. So it's not simply that our brain just shuts off when we go to sleep, it's our brain goes into different stages of sleep, okay? You may have heard of REM sleep, all right? And what happens is the body of the brain cycles through these different stages of sleep, and that gives it what we call sleep architecture. So again, this whole theme of sleep quality and sleep quantity are tied into each other. So somebody could sleep 8 hours, but if the quantity or the quality is okay, but the quantity is okay, but the quality is not, they may wake up and not feel good, okay? So to kind of drive that point home, what happens is if we look at people who are in a sleep lab, okay, what we do is we add up all the amount of sleep that they're getting, okay, all the different stages of sleep, and you'll see here on the right, W and 1 and 2 and 3 and R. What these are, so W is wake, okay, so that's being awake. N1 is very, very light sleep. This is kind of the sleep you would get on like if you fell asleep during a lecture, not this one, right? Very light sleep, unrefreshing. N2, that's kind of the baseline of our sleep. That's where we spend most of our time. N3 is that very, very deep sleep, okay? And then R is REM, okay? So that's when we dream, all right? So what happens is over the course of a normal night, the person's brain may actually wake up quite a bit. I was surprised when I first learned about this, okay? Look how many awakenings they have, a normal person. Now, this doesn't necessarily mean that they're consciously awake like we are now, but their brain kind of what we call arouses, okay? But the important thing is they get right back to sleep and the sleep architectures remain, okay? You may have heard people say we have 90-minute sleep cycles. What that means is that we cycle through the different stages of sleep, and then we end with a period of REM. You see that here? Then the person goes into lighter sleep or wakes up, and then the cycle continues again. REM, wakes up, REM, wakes up, REM, okay, all throughout the night, okay, and that's normal. Contrast, and REM, by the way, that's dream sleep, okay, so that's when we tend to have our dreams. Contrast this to somebody who has a sleep disorder. Look at the difference, okay? So first of all, in this case, this person is spending a lot more time awake, okay? You can see that. If they do fall asleep, they wake right up and they stay awake, all right? On top of that, the quality of the sleep is very impaired, okay? So you can kind of see here where my mouse is, this is that N2 sleep. They're really just getting a little bits of that. They're not getting any M3 and not getting any REM, okay? So in both of these cases, these folks may say, yeah, I'm spending 8 hours in bed. The person up top may feel fine. The person at the bottom is going to feel like garbage, okay? So what are the sleep disorders? Well, what happens is there's many of them. The ones I have highlighted here, the ones I'm going to spend more time on today, sleep apnea, insomnia. I'll talk about restless leg syndrome a little bit at the end, maybe a little bit about narcolepsy and other parasomnias. These are things where abnormal movements or so that we do throughout the night. These sleep disorders can really impact how we sleep at nighttime, how we feel the next day, but more importantly, our health, our long-term health. Okay? So let's talk about it. So sleep apnea, that's a condition where people talk about that quite a bit, but I find nobody really explains it. What it is. And essentially what happens with sleep apnea, the way to think of it is, it's repetitive stoppages of breathing that happen throughout the night. If we focus here, okay, back the area behind your tongue, what happens is when we're awake, our brain is telling our muscles to stay where they are. So the airway is wide open. When we fall asleep, the muscles in our body relax, okay? So the airway muscles, as they relax, they tend to kind of creep in together. Imagine the tongue kind of falling backwards. Okay, when the airway gets very small, which happens to a lot of people, as we breathe in and out, that the tissue starts vibrating. And that vibration is what snoring is. Now, snoring doesn't hurt you, okay? It annoys your bed partner, right, and other people in your house. But what we care about is the next step. So awake, asleep, snoring, and then here's sleep apnea. Okay, so sleep apnea happens where the airway has closed off, and then that triggers the brain to say there's something wrong here, okay? You don't die in your sleep, right? It doesn't work that way. What happens with sleep apnea is you have these repetitive stoppages of breathing that happen throughout the night, and what that does, that kind of makes the body not rest. So let me show you this in a picture. So what we're looking at here are three different people, okay? This person up top is somebody on their back looking up at the ceiling. The airway in red here, okay, this is what we're looking at. This is the airway in question, okay? So this is a nose, this is somebody's head, this is the back of the head, here's a tongue, okay? So the airway in this picture is wide open, no problem. Down here, you can see that the kind of air space is a little bit smaller. So as this person breathes in and out, the tissues are going to vibrate. That's what snoring is. Snoring is not a problem. Now, down here on the third picture, this is what sleep apnea is, okay? So the airway has totally collapsed. Airway closes off, the brain doesn't want to die, so it causes the person to either fully wake up or partially wake up. And what that does on a small scale raises the blood pressure, raises the heart rate, okay? And that over time, decades, can lead to high blood pressure, heart disease, strokes, so on and so forth. So this picture just showing, like many things in life, the older we get, the more severe or the more likely somebody's going to have sleep apnea, okay? This is kind of an unfortunate slide. What we have here is looking at 4 different groups, okay? And over on the right here where my mouse is, AHI, that's basically just the apnea index, the apnea number. Less than 5 of those, 5 stoppages per hour is normal, okay? So these are normal folks, okay, right here. 5 to 15 per hour, that's mild sleep apnea, okay? 15 to 30 per hour, that's moderate sleep apnea, and then more than 30 per hour is severe, okay? So we're looking at the different severities of sleep apnea. Over here on the y-axis, we're looking at percentage of people surviving after they've been diagnosed, okay? And then down here on the x-axis are the years after the diagnosis, Okay, so you can kind of see here as we go along after 10 to 15 years, the folks who have severe sleep apnea, they're really at risk. And again, that's heart attacks, strokes, heart disease, that sort of thing. Okay, the mild to moderate cases, sure, they're probably impacted, but not to the same degree that severe are. So what do we do about this? Okay, how do we take care of this problem? So the most common and the most studied thing we have is what's called a CPAP machine. That's continuous positive airway pressure, CPAP, the dreaded CPAP machine, right? Although the picture and these people in these pictures look pretty happy. So what this is a mask that goes over the nose, okay, or in the nostrils. There's many different kinds. These are actually somewhat old, believe it or not. And the whole idea is it's connected to a tube, which is connected to a box. And what that box does is it blows pressurized air, kind of like a vacuum cleaner in reverse. Pressurized air, which comes into the nose, goes all the way down to the back of the throat, and it forces the airway open. So all this that I showed you before, including the snoring, would go away, okay? It's kind of like an airway splint. Keeps the airway wide open, and the person is allowed to breathe on their own. It's not like they're in a ICU or on a ventilator or so. This is a very, very simple, straightforward thing where the pressurized air is keeping the airway open. Another graph showing you how when you have untreated sleep apnea, the effects, and then when we treat it, what happens. So what we're looking at here is cardiovascular event rate. These are heart attacks and strokes, okay? Over here, we have 5 different groups. Controls who have nothing, people who snore, people who have that mild to moderate sleep apnea. You can kind of see a little bit increased risk, but nothing major. The untreated severe, major risk, okay? And what happens is when you put these folks on CPAP, that risk basically goes down to nothing, okay? So very important study, very cited study, showing how good CPAP is. Unfortunately, not everybody can tolerate CPAP, okay? And that's for a lot of different reasons. That could be because of claustrophobia, it could be discomfort, it could be, for a variety of different reasons. Thankfully, we have other things. So the second line that we have is what's known as a dental device or an oral device for sleep apnea or a mandibular advancement device. What this is it's kind of like a mouth guard, a sports mouth guard that gets molded to the upper and lower teeth, usually by a dentist. Once it's molded and fashioned and adjusted, what this essentially does is it pulls your lower jaw, if you can see me, it pulls your lower jaw forward a couple millimeters. Now, why that works is it takes the base of the tongue away from the back of the throat. Again, that's the key thing here is the airspace behind the tongue. Opening up that airway is effective, okay? This is not as good as CPAP, but in a case where, let's say somebody has the option of using this or the CPAP, which is better, but it's sitting in the closet, I want to use this, okay? The other thing I to mention is insurances won't always cover this, whereas CPAP they will. And these are a little bit harder for a doctor to tell if a patient is using this or not. So CPAP, it's very easy. We can take a look at the machine data and see if the person's using it every night, and it's very effective. With oral devices, we don't have that capability. So what other things are out there? Well, there's surgical approaches. So the most common one, the one you may have heard about, is the UPPP. It's a uvulopalatal-pharyngoplasty, which is a mouthful, literally in this case. Kind of fallen out of favor in recent years because it doesn't really work that well, but it is out there. Essentially, what'll happen is the ear, nose, and throat surgeon will go into the back of the throat, and either with a scalpel or radio waves, will essentially take out all of the extraneous tissue. So the uvula, the little thing that hangs in the back of the throat, the tonsils, they'll just cut it all out, okay? And that seems like that would work very well, right? Opening up the space. The problem, though, is that you're leaving the tongue, right? The tongue is not going anywhere, and the tongue, as we said before, is really the major problem here. So a lot of times what will happen is people who get this procedure, they'll say, I'm not really snoring anymore because the thing that causes snoring is gone, but I'm still having these issues, okay? So it's kind of fallen out of favor, but people still do it. What else can we do? Weight loss, a big one. Exercise, even despite weight loss, exercise can be very helpful. Positional therapy. What I tell all my patients is you want to avoid sleeping on your back. If you're flat on your back, gravity is kind of pulling everything down towards the back of the throat. It's going to make your airspace smaller. Be on the side, the best way. You can sleep on your stomach too, but your stomach, you're putting a lot of pressure on your neck and your lower back, so that may be a little uncomfortable. So the side, the fetal position is the best. Sedatives, alcohol, big one. Ambien, another one. Xanax, Klonopin, things like that. These can all make sleep apnea worse. Okay. The new kid on the block is what's known as a hypoglossal nerve stimulator. You may have heard about this. They're advertising a lot now. What this is basically is a device that gets implanted into the chest. It's kind of like a pacemaker almost. The device gets implanted. There's a wire that goes underneath the skin, which controls the nerve, which controls the tongue muscle. Okay. After this is set and calibrated and healed, what the person does is they turn it on with a remote at nighttime. And basically what this does, all this does, is we keep saying the tongue is the problem. This device stiffens up the tongue. Okay, it sounds very Twilight Zone or science fiction-ish, because it is. This device stiffens up the tongue and it prevents it from falling backwards. Okay, it works very well, but it is a procedure, and I tend to reserve these more for like cases where somebody can't use CPAP or they're very severe and there's no other option. Okay, but just know about it. All right, so that's sleep apnea. We're going to switch gears to insomnia, of which sleep apnea could be a cause of, right? Insomnia is a difficulty either getting to sleep, staying asleep, or sleep that is chronically non-restorative. Okay, so sleep apnea could fit those categories, right? So sleep apnea is a very, 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 very common problem. People see their primary care a lot. They've come to see me for this. Very, very common. And there's different reasons as to why it happens. There's different ways to take care of it. And we're going to kind of go through it now. So just like sleep apnea, the older we get, the more likelihood insomnia is going to happen. That's because of hormonal changes. That's because of weight gain. That's because of other medical problems. That's because of sleep apnea. Okay. You guys remember the Lockhorns? No wonder you have insomnia, lying there awake all night, right? So what are the different types of insomnia? Well, acute insomnia up top there, we've all had that. That's I have a test tomorrow, or I'm giving a talk, or I got a promotion, or it could be something good. Just there's something exciting in your life and you can't sleep. Very common, not a big deal. Inadequate sleep hygiene, what that is basically, and we're going to go over this, is using the bed for things other than sleep. So I've had patients eat in their bed. I've had patients watch TV in their bed, read in bed. I mean, all these kind of things. Reading is not that bad, but other things, doing them in bed for prolonged periods of time, especially here in Manhattan, where people, we don't have very big places, using the bed for things other than sleep, what that does is that it makes the brain, it tricks the brain a little bit. Like, is this bed my place of sleep, or is this my place of doing homework? Is this my place of sleep, or is this my place of being stressed out? Is this my place of sleep, or is this my place of, watching TV and movies for hours at a time? Okay? That's not a good thing for long-term sleep. Psychophysiologic insomnia, we're going to talk more about this in a second. This is folks who let's say were good sleepers, then something happened and now they're not. Okay, we're going to talk more about that. Idiopathic insomnia, these are people who have not been sleeping well their entire life. Very difficult to treat. Anytime you see the word idiopathic in medicine, it means we don't know why. Okay. Paradoxical insomnia, this is really interesting. These are people who swear that they don't get any sleep. Okay, I've heard people come to me and say, I have gotten 1 hour of sleep a night the last 30 years. Well, what happens is if you got 1 hour of sleep for 30 years, you'd be dead. There's no way you'd be alive. So when these folks, we do a sleep test, for example, and we show them, hey, look, you slept 7 hours. And that in some cases is curative. You see this a lot of times with people who have severe anxiety disorders, things of that nature. And then the last one, any kind of insomnia associated with, a chronic medical problem like diabetes, for example. People have to go to the bathroom. If people have men have prostate issues, that can cause them to wake up quite a bit. Okay. So what are the risk factors? Well, certainly having a prior history of insomnia, a family history of insomnia, psychological vulnerability, like I said before in the beginning of this talk, depression, anxiety, huge things that cannot be overlooked. Many substances cause insomnia, okay? The three big ones, which we're going to talk about at the end, nicotine, alcohol, and caffeine. Those are the three killers, okay, that I see all the time. Caffeine, can stay in your system longer than you think. People don't realize that caffeine can have a half-life up to 5 hours in some people. What a half-life is basically after X number of hours or minutes, half of the substance is still around. Okay, so having a half-life of 5 hours for somebody, let's say you have a cup of coffee at 5 p.m., right? You think, okay, I get that boost of energy, it's out of my system by bedtime. Not necessarily. That little bit of caffeine may be still floating around in your system. And if you're somebody who has even a little bit of sleep trouble, that little bit of caffeine can kind of flip the balance, okay, and make it harder for you to fall asleep at night. Even decaf can have caffeine. Alcohol can help us to fall asleep a little bit easier and actually can help us to stay asleep for about an hour. Then once we start metabolizing it out, it can really screw up our sleep, especially if there's sleep apnea, okay? And there's many other reasons why many other medications that can cause insomnia, but I would say those are the big ones. Okay, so when we talk about psychophysiologic insomnia, like I told you a couple of slides back, or conditioned insomnia or chronic insomnia, there's something called the 3P model, okay? And this was designed in the 80s or figured out in the 80s by my late colleague, Art Spielman, one of the giants in the insomnia or sleep world. And basically what it is this, the 3Ps. So P1 is predisposing factors. So these are people who have vulnerability, anxiety, depression, social issues, biologic trait, family history, okay? But their sleep problems would not really come to a head unless it was for the second P, precipitating factors. So they go through a medical illness, they go through a divorce, it could be something good, they could have a promotion, any kind of stressful life event, right? A pandemic. All of a sudden now, that predisposition ramps its head, okay? And now these people are really having trouble sleeping. Then we go back to quote normal if it wasn't for the third P, which is perpetuating factors. And that's the bad sleep hygiene, spending too much time in bed, doing things in bed besides sleeping, napping too long, okay? And that's where we as sleep specialists try to improve things, okay? So that's the chronic model, the model of chronic insomnia. So how do we take care of it? Well, certainly, like I keep saying, if there is any psychiatric illness, you want to take care of that, okay? That being said, what we'll do is a combination approach of what's called cognitive behavioral therapy or cognitive approach to sleep apnea, behavioral approach to sleep apnea, along with medications, okay? So the behavioral stuff we do, these are the three probably big ones I would say, is listed here. So probably the strongest thing we have is up top. It's called sleep restriction, okay? And what that is the best way to explain this is with an example. Let's say there's somebody who gets into bed at 8 p.m. They get into bed, they're just lying there for hours and hours and hours, and then they don't fall asleep until maybe 1 a.m. Okay, so they're in bed 8 p.m. to 1 a.m. Then they fall asleep at 1 a.m. and from 1 a.m. to 8 a.m. they're waking up every half an hour or so. Okay, so this person in this example is in bed from 8 p.m. to 8 a.m., 12 hours. But because they have trouble falling asleep and they have trouble staying asleep, they're only getting, let's say, 5 or 6 hours of sleep. What I would do in that case, and this is what sleep restriction is I would cut down their time in bed. So I would say, okay, person X, instead of getting into bed at 8 p.m., let's have you delay that to 1 a.m. And instead of having you get out of bed at 8 a.m., let's have you get out of bed at 7 a.m. Okay, so we're cutting a lot of at the front end and a little bit at the tail end. And invariably, they're going to say, well, how is this going to help me? I'm already not sleeping enough. This is crazy. And they're right. But what happens is if you do this, okay, not over one night, but if you do this over weeks, what happens is, and you don't take naps, what happens is the body starts to tire itself out, okay? And that's a good thing. By tiring itself out and then giving it this window of time, the brain almost starts to rewire itself. Okay, this is the only window I have, so therefore, what happens is the person starts falling asleep a little bit easier. They start staying asleep a little better. The sleep becomes more continuous and higher quality, even though the quantity is not there, the quality is higher. And then what we do is over time, over weeks, let's say, what we may do is open up the window a little bit. So instead of 1 to 7, maybe we'll do 12:30 to 7, okay? So on and so forth. All right, very effective, very hard to do, but it does work. Okay, and there are other techniques here. Fortunately, we have psychologists who do this kind of work, and that's usually what I refer to in a case like this. Okay, but this is the behavioral treatment that we use for sleep apnea. So it's not simply just behaviors. It's also a modification, and or excuse me, it's not only behaviors. It's also medication. Sorry, Kayla, I'm trying to hide this thing again. This panel.
Yeah, unfortunately, I don't think there's a way for me to do it since we're mid-webinar, so I'm just putting
Okay.
people's hands down.
I actually think I was able to do it. Okay.
Okay, great.
So basically, when we talk about the two-pronged approach, behavioral treatment, but also medication, okay? And medication for insomnia can be a whole talk on its own, all right? But basically, the highlights here are, if somebody has not tried anything yet, usually what I will do, start off with, is melatonin. Melatonin is safe. It's something that our brain naturally makes. When it gets dark outside, the brain starts to produce melatonin, and that can help us to fall asleep. Now, they sell it in pill form, not addictive, not harmful. You may read, oh, you're not supposed to take melatonin for more than 2 weeks or some garbage. What that's saying, I think what they're trying to get at is, if you're not under the care of a sleep physician, or if you're using melatonin to maybe mask a condition like sleep apnea, yes, I agree. It's not a good thing. But if you're coming to see me and you're under my care, melatonin is safe. And not just me, my sleep brethren. Okay, so melatonin can be useful. They come in immediate release, which is I would use if somebody has trouble falling asleep. And they also have time release. Okay, there's one brand I like called REM Fresh. That's REM Fresh. What that is time release melatonin, and I trust their brand. They sell this on Amazon. It comes in 2 milligram and 5 milligram pills. What I'll usually tell somebody is, look, if we haven't tried anything yet, you're having difficulty staying asleep, maybe try the 2 milligram pill, see if it helps. Okay. The other medications, the Ambien, Lunestas, all that stuff you've heard about, I try to avoid that if we can. I prefer trazodone, okay, which is it's basically a very mild antidepressant. Okay, we use it in the sleep world because it has kind of a two-pronged effect. Quiets the mind down, helps also induce sleep. It is a sleep aid. Okay, like I said, I'm just giving you really bullet points here. This could be a talk unto itself. All right, but treatment of insomnia includes not just throwing medication, here's Ambien, goodbye. It's behavioral changes and then working within the context of these things we mentioned here. Trying to avoid addictive or harmful medicines. Switching gears again is restless leg syndrome. And I'm just going to kind of fly through this because I want to get to questions at the end. This is a condition where people think it's like a joke diagnosis, but it's not. If you have restless legs or know somebody who does, this can be hell. What it is a condition where we call it the urge criteria, URGE. That's urge. People have the urge to move their legs before bed. R is it happens at rest. Okay. G, when they get up and go, the symptoms go away. And then E, it happens in the evening time. So what does this all translate to? Let's say you work a long day. You come home, you're tired, you get into bed. You start getting into bed, you start, winding down, and guess what? You get this incredible sensation of kind of annoying or kind of a creepy crawly sensation, sometimes pain in your lower leg. And what that does, that prevents you from falling asleep. So what do? You get up to walk around. It goes away. You say, okay, I don't know what that was. You go back to bed, boom, the same thing happens again and again and again and again, all throughout the night. You can imagine this would be very, very, very difficult to deal with. And people with RLS, restless leg syndrome, they will be struggling, okay, especially in a severe case. So it's bad for the reasons I just said, but it also has this kind of corollary to it called periodic leg movements of sleep. And these are people who are, if you look down here on this bottom picture, the legs are just going throughout the night. Okay, so that can wake them up, certainly can wake a bed partner up. All right. So what we want to do in restless leg syndrome is we want to take away any offending agents. Okay, so things that can cause it are the ones that the biggest one I see is like Benadryl type substances. People may take Benadryl to help them sleep, which I don't recommend because it can affect memory, but it also can make RLS worse. Okay, if there's other underlying medical problems, okay, like fibromyalgia or neuropathy, nerve pain, you want to take care of those. Usually what we'll do in a case of restless leg syndrome is we'll look to see if the iron level is low. If somebody's anemic, let's say, that can be a cause, and we try to treat that, okay? Stretching before bedtime, like this person is here, that can be helpful. And then we have medications, okay? Again, this can be a talk unto its own. If it looks like I'm going fast, because I am. Parasomnias, what are these? These are abnormal movements or behaviors that happen as we're going into sleep or as we're waking up from sleep. Okay, they can be something as simple as nightmares. It can be something as complicated as sleepwalking. Okay, they can be disruptive to the bed partner. They can be dangerous to the patient themselves. Okay, and basically what we do with any kind of parasomnia is we want to see is there an underlying cause. Okay, all the things we're talking about today, it's the big question is there an underlying cause? Okay, so if somebody has sleep apnea, let's say, for example, you treat it, the parasomnia may go away. Okay, if somebody has underlying psychiatric conditions, treating that can help the parasomnia. All right. One of the big ones that we see is REM behavior disorder. So this is a condition where people act out their dreams, okay, when they shouldn't. So you can see here on the left, this gentleman is having a dream that he's in a boxing match. Okay. Normally, when we're in REM sleep, our body is paralyzed. What's happening here, though, is this person is allowed, if you will, to act out his dream. So instead of him being in a paralyzed state and dreaming away peacefully, he actually starts, throwing punches. Hit his wife, he can hit himself, he can fall out of bed. I've had patients break their hand or break their hip. Okay. It's very disruptive to a bed partner or the patient himself. But the real reason we care about this is because it can be associated with things like Parkinson's disease down the road. Okay. So again, this is something where you come to see me for. Narcolepsy, same thing. Narcolepsy is a condition where, you see it in TV shows and movies and stuff, and you're talking to someone, all of a sudden they just, pass out in front of you. Now that can happen. That can be that severe. However, and usually in most cases, this is a condition where somebody is just tired all throughout the daytime. Okay, with no real explanation as to why. I get 8 hours a night. What's going on here? I'm falling asleep in class. I'm falling asleep in meetings. God forbid I'm falling asleep while driving. Okay. In this condition, people, think that people develop complexes like, oh, my family says I'm lazy, or, I'm maybe depressed. That's not so. What happens in narcolepsy, there's a hormone which basically keeps us awake. That hormone is lost, okay, either from genetics or from a severe head trauma. And as a result of that, these sleepiness, this excessive sleepiness can result. On top of it, they can have what we call cataplexy. So if we look down here, this girl, she's on a swing, she's laughing, she's having a good time. What happens with cataplexy is when somebody is in an emotional state, whether it be laughing or joy or whatever, they lose muscle tone. So they all of a sudden become paralyzed, okay? And they fall to the ground, or they drop cups or whatever it is, okay? Very treatable, but it also takes a long time to get diagnosed because people get misdiagnosed, all right? So those are the main conditions I wanted to talk about. And now I just want to kind of wrap it up, and then we'll take questions. So I put together this 12 steps to improve your sleep, okay? And this goes for anybody. But what I always say is if there's any possibility of having any of these sleep disorders that we mentioned, and we're recording this so you can go back and watch, you get tested, or at least go see one of my colleagues, all right? Because that's not something you wanna miss, because it can affect your day-to-day life, but also your long-term health. Okay, that being said, step one, caffeine, alcohol, nicotine, the big three. Okay, we already talked about caffeine, alcohol we mentioned, nicotine, you shouldn't be smoking anyway, but these are all things that can affect your sleep. So if you're gonna use them, earlier in the daytime. Especially with caffeine, I say maybe 1 to 2 p.m. be your cutoff. Number two, turn your bedroom into a sleep-inducing environment. So what does that mean? So you don't want to, well, let me put it this way. You want your bed environment to be considered a sacred place, okay, where you do your sacred act of sleeping, okay? And when you're doing things in your bedroom or your bed, aside from sleeping, you're desecrating that sacred space, meaning that you don't watch TV in bed for hours. You don't, I mean, you can read in bed, but maybe 15, 20 minutes or so before you go to sleep, no problem. If you're reading in bed for hours or doing homework in bed, that's not a good thing. Okay, we want the brain to know this bed is my place of sleep. Okay, so you do that. You cover the clocks in the room, okay, which is number 5. All right, that's having that kind of relationship with your bed environment can be very helpful. Number 3, establishing a soothing pre-sleep routine. One of my favorite things to do is meditation. Okay, mindfulness or guided meditation. There's millions of apps and videos out there. The Calm app, the Headspace app, all can be very helpful. What I usually tell people is 30 to 60 minutes before bedtime, shut off the screens, the iPads, the iPhones, the computer, the desktop, the TV, okay? Anything like that that has a screen. Even some of these e-readers I'm not a fan of, okay? Anything that has a light source that kind of comes from its own, the screen has a light on its own, you want to avoid because they emit what we call blue light. And blue light shuts off your melatonin. So what I would say instead is 30 to 60 minutes before bedtime, read on paper, listen to music or a podcast, meditate, okay? Number 4, go to sleep when you're truly tired or go to bed when you're truly tired. Unlike that example I talked about earlier where somebody gets into bed at 8 p.m. and they're not falling asleep till 1 a.m., that's not a good thing. We want to match or closely match the time that we get into bed to the time that we would fall asleep, okay? And even if that means delaying your bedtime a little bit. Don't be a clock watcher. So what I recommend people do is just cover the clocks. You know, you have to set an alarm, do it, but turn it face down. You know, you don't want to see what time it is throughout the night because that can keep you awake. Use light to your advantage. So at nighttime, 30 to 60 minutes before bed, you're shutting off the blue light, okay? But when you wake up in the morning, open up the windows, get some sunlight. You know, you're not going to stare into the sun, obviously, but get some sun on you. What that does, it tells your brain, hey, it's time to be awake. Shuts off melatonin, gets you ready for the day, okay? And that's how your brain kind of gets entrained, if you will. That's your circadian rhythm, okay? Number 7, keeping your clock set with consistency, all right? So one of the biggest things we see is, let's say somebody is kind of sleep deprived a little bit during the week, you know, Monday through Friday. You're only getting, let's say, 6 hours a night. And then on the weekends, they sleep for 10 hours. And then what happens is they sleep in Sunday morning, and then Sunday night comes and they can't fall asleep, okay? That kind of inconsistency and that all over the place, that makes them have a bad night Sunday night, and then Monday they're sleep deprived, and the whole process continues again. It's really important to try to be getting your consistent 7 to 9 hours, that's what the average person needs, every night, okay? Nap early or not at all. So naps can be very, very helpful, okay? I showed you in the very beginning of the talk, when I took a nap when I was pulling my all-nighters, that helped me to retain my information. I don't recommend that, but if you do have to nap or if you're a little tired, fine. Try to keep it early in the day, you know, maybe by 1 o'clock or so, latest, and try to keep it short, 20 to 30 minutes, okay? What can happen is naps are a slippery slope. So if you start napping a little bit later or taking naps that are 45, 60, 75 minutes, at nighttime when you want to go to bed, your brain says, well, I just slept. I can't go to sleep now. All that sleep pressure, as we call it, is gone, okay? One of the biggest things I see is people get home from work, you're tired, you have your dinner, you're sitting in front of the TV, and you take a 15-minute nap when you're on the couch, dozing off, right? It seems like an innocuous thing, but again, when you try to fall asleep at nighttime, that can be a problem. Lighten up on evening meals and fluid intake. So you want to have your 8 glasses of water throughout the day, okay? To show you I live what I preach. You want to have that throughout the day, but an hour or 2 before bedtime, stop that, or even earlier, okay? You want to have your normal meals. You don't want to go to bed starving. You also don't want to get to bed hungry. If you're very hungry before bed, maybe a couple crackers, a little bit of peanut butter, that would be fine. Morning exercise, cardio exercise, super helpful. Across the literature, across the board in literature, people who exercise early, especially as they get older, have better sleep at nighttime. What I like to do is combine early or morning cardio exercise with meditation at night. And then finally, follow through. None of these things that we're talking about are going to help you over one night. Okay, so it's not gonna work overnight, pun intended. Okay, so you got to keep with it. This is just a little blurb on meditation. Okay, I'm a big believer in it. The literature agrees. All right. If you're interested in more information, my book came out in 2018 called Let's Talk About Sleep. And I have a YouTube channel also called Let's Talk About Sleep. So you can engage with me there. And I will now take some questions.
Thank you so much, Dr. Barone. If you want to
Sure.
cut your screen share, you and I will be big for people to see, like side by side. That works.
Sounds good.
I might be able to even do it for you. Yep, there it goes. Okay, so now we're side by side.
Cool.
All right, so people were super engaged. I think we have close to 200 people on with us who all stayed, so I don't think anyone fell asleep. But
Good.
we had a few questions come in about dreams. So
Yeah.
I think I'll start with those. They're all kind of related questions, so I'll kind of bundle them if that's okay.
Sure.
Someone
Yep.
asked, why do we remember some dreams but not others? And if dreaming is an indication of good sleep.
Yeah, great questions. So dreams, believe it or not, we're still not even sure what they mean. Okay, there's different theories as to why we dream or what happens when we dream. You know, some people say that we're consolidating memories. Some people say that we're kind of getting rid of the garbage that we don't need, and that's why the dreams have bizarre content. The point, though, is we do dream throughout the night. Whether or not we remember it is a different story. Okay, so we tend to have our most memorable dreams, let's say, during REM sleep. If you remember that picture I showed you before of the different stages, right? Every 90 minutes or so, we're in REM sleep. Now, just because you don't remember your dream doesn't necessarily mean that you're not dreaming, one, and it doesn't necessarily mean that you're not getting good quality sleep. However, what I see quite often is when people have a severe sleep disorder, like let's say obstructive sleep apnea, their sleep is very, very chopped up. They're not able to kind of get and stay in good quality sleep. And as a result of that, they never dream. But guess what happens? We put them on CPAP or whatever it is that we do, and they'll say to me, Dr. Barone, I'm dreaming now like I've never done before in my life. I'm every night I'm having these crazy dreams, and it's because they never were getting into REM sleep, prior to that. So it's kind of a politician's answer, but it's hard to tell just without knowing the bigger picture.
Sure, that makes sense.
Yeah.
Another person asked, is it okay to get 8 hours of sleep but in increments? So I know you talked about with some of those different diagrams when people are waking up throughout the night. This person asks, for example, maybe a 2 to 4 hour nap, but then the remainder of those 8 hours, like a 4-hour chunk of sleep at night.
Yeah.
Is that okay?
So yeah, that's like we call it polysleep. Inventors, like I think Thomas Edison used to sleep that way. Leonardo da Vinci slept that way. Okay. If you have your own inventing lab and can live that lifestyle, it's probably not that big of a deal. But the problem is when you have that polysleep, it's a very slippery slope. And what can happen is you can start to develop insomnia because the nap you get in the daytime becomes too long, and then you can't fall asleep at night at all. And then it kind of flips your schedule. It's not a recommended thing. But the bigger question is, though, is why you're doing that, right? Why is the person doing that? Why can't they stay asleep? And that question is answered by like a sleep test, for example. Like, is there an obstructive sleep apnea? I hate to keep using that term, but that is a big thing that's very often overlooked.
Thank you.
Yep.
So kind of on the opposite side of the spectrum, if someone is sleeping for more than 8 hours, should they set an alarm so that they kind of are maintaining that maybe less sleep or more of like a sleep hygiene, whatever you would call it? What's your recommendation there?
Yeah, well, these are great questions. I'm very impressed with this group. It kind of depends. So the average person, National Sleep Foundation published a paper in 2019, I believe. The average person needs 7 to 9 hours, the average adult, okay? So there are people who need less, there are people who need more. What I would say is the only way to answer that, the only person who can answer that is you, right? So if somebody sleeps, let's say somebody has like major depressive disorder, okay? So they really are clinically depressed. That person may sleep 11 hours a night. And they'll say to me, I get 11 hours. We did a sleep test. There's no sleep apnea. What the hell's going on here? Why am I so tired? They're actually oversleeping. And what can happen in there is what we call sleep inertia, where somebody goes to bed and it's like this, like inertia, right? It's like this train that's rolling and they can't stop. And waking up from that, they can actually be more tired than they were before they went to bed. Okay, it's almost as bad as not sleeping at all. So what I would tell you is 7 to 9 hours is the benchmark. But if you're sleeping 8 hours and still tired, you definitely want to get yourself tested. Okay.
Great.
Yeah.
So a few people asked about melatonin and just in terms of dosage, like milligrams wise. And I think like if you have any brand you could recommend, there were a few questions about that.
Yeah. So the time release version. Okay. So here's the thing about melatonin. It's not FDA regulated, right? So you go into Joe's pharmacy, you don't know what the hell you're getting in some cases, right? So there are some good brands out there, Nature Made, and I don't endorse any of them, but I'm just saying that they're out there. So for the immediate release, usually what I start with is if somebody has trouble falling asleep, 1 to 3 milligrams. Okay, so you get that at any Dwayne Reed or whatever, just look for whatever brand they have, and go from there. For staying asleep though, there is a specific brand I recommend called REM Fresh. I said that earlier. REM, like REM sleep, fresh, and that comes in 2 and 5 milligram pills. Usually, what I have people do is if there's trouble staying asleep, start with the 2. But again, right? The big question is you don't use melatonin just as a band-aid. You really want to get that looked into if you have trouble staying asleep.
Thanks.
Yeah.
We have 2 more minutes. I think we could squeeze in maybe like 1 or 2 more questions.
Sure.
We did have a question come up about restless leg syndrome. I thought this was an interesting question.
Yep.
This person says, should I use my mind to resist the twitches or is it better to let my leg do like the movement?
Yeah, so that's not really, I don't have a good answer in the way that question was asked, but what I would tell you is what we consider to be one of the treatments is to get your mind off the symptoms. Okay. So people have recommended video games even, or, knitting or talking on a phone or doing something to kind of get your mind off the symptoms. That can be very, very useful, okay, in conjunction with medication or stretching or, again, having blood work done. But getting your mind off things, so if that's kind of what you're asking, definitely do that.
Great, thanks.
Yeah.
I think we'll end with this last one.
A few people more if you want.
Okay. Yeah, let's see how this goes. Someone asked about kind of, people brought up apps that kind of track your sleep, whether it be on the Apple Watch or like a computer app. What you think about that, and if you could recommend any online CBT program.
Yeah. So the online CBT programs, there really was a great one called iSleep, but they discontinued it for some reason. That was really, really helpful. Unfortunately, I don't have a good one right now, but there are definitely practitioners out there who do that. Okay, psychologists. So CBTI, just look that up, and you'll find someone in your area. Or look up on your insurance website. The app question. So I have kind of a love-hate thing with the apps. They can be helpful insofar that they get people paying attention to their sleep. But as far as the data that come from them, they're just not high quality enough yet for me to do anything with it. So people come to me with reams of data from their apps. I just tell them, I'm like, look, I don't care about that. I want to know what your story is. Tell me what's going on from your subjective experience. The apps are just, well, look, I got deep sleep. There's no way. We need an in-lab test to really get that information. So the apps can be helpful in that they get you paying attention, but you don't want to go too far where you say, well, the app is telling me this, but I feel this. I want to know what's going on with the person.
Mm-hmm.
Yeah.
Thanks.
Yep.
If you're willing, I could ask one more question. It's up to you.
Sure. Yep.
Okay. So someone asked, how do we measure time asleep to account for the time we are awake each night that we don't know about? So kind of how is someone knowing if they are getting enough hours if it's not consecutive?
Yeah, well, I mean, the only way to answer that is, again, by doing a sleep test. An in-lab test would help us to kind of see that, even though it's not a perfect situation because you're covered in wires. But what I would say is with a lot of these questions, it's kind of how you feel, right? So if you're getting, let's say, 8 hours a night, right, and you wake up exhausted, something is obviously wrong, okay? Whereas if you're getting 7 hours a night and you sleep all the way through and you wake up and you're bouncing off the walls and you feel great, keep it up. So it kind of depends on the subjective experience. It's not really a great answer yet. maybe down the road when we have more advanced wearable technology, we will be able to answer that question in a kind of more real-time way. But as it is now, we don't.
Got it.
Yeah. Okay.
Well, thank you so much for your time. I really enjoyed your presentation and how you started with kind of the research and you ended on your book and those 12 tips. And I think our audience probably really enjoyed lots of questions, super engaged.
Well, yeah, it was great questions. Thank you again. And like I said, my YouTube channel is out there. Buy my book if you want. But what I always say, if there's any problem, if there's anything that you think is not right, go get an evaluation. There's no reason not to, honestly. All right?
Totally.
All right.
Thank you so much, Dr. Barone.
All right. Take care, everyone. Sleep well.
Have a good night, everyone. Thanks for tuning
Bye-bye.
in with us.